Nel, it's so wonderful to be here with you today. Thank you so much for making the time to talk to me.
Well, thanks for having me. It's great to be here.
So I want to start this morning by going back in time. And I want to go back to the first time that you and I met, which was around, I think, 1998 or 1999. I was a medical student at McMaster, and you were the chief resident in psychiatry, Chief Nel Wieman. And I want to start there with who you were at that point, the weight that you carried, and what the expectations for your career were back then.
Thanks. Yeah, that seems like such a long time ago. I think at that point, there was another Indigenous psychiatrist who came before me. His name was Dr. Claire Brandt, and I always acknowledge him because he was the first. But he died, unfortunately, when I was in the second year of my residency. And so then I became the only Indigenous psychiatrist in the country and the first female to train as a psychiatrist. And so at that time, I think I kind of almost in a way had two careers, right? I was like working in the medical system, you know, working as a chief resident and all the duties and responsibilities that came with that. And then at the same time, I was starting to build this career as kind of, you know, someone who could speak up on behalf of First Nations people and advocate for improved mental health and health overall. I do remember that time. I felt a lot of responsibility.
Yeah. I think one of the things that I just as a bystander remember too, I mean, there was media coverage about you. There was a big article in the newspaper about you sort of carrying this mantle and this weight. And I wonder, even then, looking back, what do you think was the impact of that weight at that time?
You know, I think for myself, I do remember one article that came out around that time. And I remember somebody wrote, I think it was in the Canadian Journal of Psychiatry. And then the next month there was a letter to the editor, something about, well, she seems like a really nice person, but she's never going to accomplish it. Like, it's just, there's too many problems. The problems are too big. And I remember reading that and then I thought, you know, like my whole career has been based on people telling me that I can't do something or that I'm not good enough to do something. And so I guess I like, why would I remember that particular letter 30 years later? So I guess I just used it more as motivation. But for sure, there was a huge challenge. I think probably the biggest tension for me was still being early in my training, early in my experience, and yet being called upon to be kind of the expert in Indigenous mental health.
We're going to talk in a minute about sort of a sequence of really difficult events that occurred in your life. But between you finishing your residency and that period of your life, could you just fill in some of the blanks professionally in terms of what kind of work you ended up doing and where you professionally found your home?
When I first graduated from my specialty training, I had the opportunity, even during my residency, to be a part of a group that was creating a mental health service on 6 Nations of the Grand River Territory, which is just outside of Hamilton. And, you know, now when I look back on it, you know, we were doing culturally safe things before it was even called that, right? I think the term cultural safety was coined in 1998 or something in New Zealand, but of course we didn't know about it at the time. So the first 8 years of my career, I worked mostly at this community-based mental health clinic on reserve, working exclusively with First Nations people. And then I did a little bit of time, some shifts in the regional emergency psychiatry department because I really loved emergency psychiatry. And then after that, you know, it was really difficult working on reserve, I have to say. You know, there was one psychiatrist that I managed to kind of cajole to come and work like a day a month or something and see the young children and the young adolescents. But primarily I was the only psychiatrist working in the community at the time. And so over those 8 years, you know, I had kind of become the keeper of people's secrets and the holder of all of those stories. And there were different traumatic events that happened in the community, really tragic death of a toddler and and all sorts of other things. And so after 8 years, I found myself feeling pretty, I wouldn't say burnt out, but probably pretty close to burnt out. And so I accepted an opportunity to move to downtown Toronto, and I kind of switched and started working in the Dalalana, what is now the Dalalana School of Public Health, in sort of a research teaching capacity. And I co-directed a research program that was intended to build capacity for Indigenous students to get engaged in health research. And I did a little bit of clinical work at the time, mainly with Indigenous, I worked with an Indigenous HIV/AIDS organization and a program for the homeless. So I've always kind of been drawn to working with populations who are in situations of vulnerability. And I did that, I think, for about 7 years. And then I took a job working as, it wasn't called an assertive community treatment team, but that's how we functioned. I worked for YWCA Toronto on a mental health team, providing support to 100 women living with serious mental health and addictions issues. And then lastly, I decided that I need a little more structure than what I was working, the situation I was working in at the Elm Center. And I accepted a position working at the Center for Addictions and Mental Health in downtown Toronto.
So now in 2005, a few really difficult things happened in your life, and they had a series of impacts that you experienced afterwards. And I wondered if you could talk for a moment about what went on starting in 2005 and the aftermath.
Even for us as physicians, life happens, right? And things got really challenging for me, I think, because so many things happened all at once. As I mentioned, I accepted a position in downtown Toronto, so that involved leaving my home and moving to downtown Toronto, which is a very different setting. My marriage ended, and around the same time, my mother, who was elderly, she was 85 at the time, she essentially went into hospital for the last time and was hospitalized for about a year of her life. And I was kind of the primary caregiver for the family because my father had already passed away. And then at the very same time, my best friend, who had been my best friend since we were 4 years old, was diagnosed with cancer while she was 12 weeks pregnant with twins. And so she made the very difficult decision to delay her own treatment so that she really wanted to deliver 2 babies that were healthy. And so she essentially sacrificed herself. And so it turned out that she was at Mount Sinai Hospital, which is right around the corner from my office. So that whole year was spent, adjusting to a new place to live, a new job, trying to look after my mother from a distance because she was living in Thunder Bay, flying back and forth at times, and then basically spending almost every day or as many days as I could with my best friend in the hospital. So it was pretty ragged, ran me ragged. And looking back on it, I don't really think I took any time for myself to process any of it. And in early January of 2006, my mother died. And then 5 months after that, exactly, my best friend died. So I lost the 2 most important women in my life in the span of 5 months.
And then what began to happen in your personal life after that?
Yeah, so things very slowly started to unravel. I think my major, being a physician and and not just being a physician, being an Indigenous physician and having leadership roles and things like that, my major response to that whole year that I had been through and all the grieving and the loss was just to work harder, to just throw myself into my work and numb my feelings and just pretend as if it was all okay, right? And of course, then as a psychiatrist, you also think, well, I'm really going through something right now and I'll be able to figure it out myself, right? That sort of notion that, when we as physicians, but also as human beings, feel capable of reaching out for help. That culture didn't really exist back then.
Yeah.
You know, that was quite a while ago. And so I just kind of suffered along for a long period of time. And I think I developed, I think, a pretty severe depression looking back on it. And my major way of coping with that was to start drinking more. I would say I was always a social drinker throughout my life, but it wasn't problematic in the sense that it didn't interfere with my life in any way or impair me. But because I started working harder, it's interesting because a lot of my work involves travel. And I think for a lot of physicians, this is the case. We travel a lot, and it's really easy to drink when you travel because you can have a glass of wine when you get to the airport, and you can have a glass of wine on the plane, and then you get to your hotel room, and oftentimes people would leave me these gift baskets that had, you know, cookies and chocolate and a bottle of wine. Well, you know, I'd help myself to that. And my major thinking at the time was I had terrible insomnia. That's actually the symptom that bothered me the most. And so the drinking at the time, even though I would advise patients not to do this, right? But for some reason, ourselves as physicians, we don't see that. We don't take that advice. So I started using wine to be able to sleep, you know, and then before I knew it, it just got worse and worse and worse. And I was waking up hungover every morning and still going to work, but definitely not feeling at my best and probably not being my best, and just looking forward to getting home from work so that I could, you know, crack open a bottle of wine and start drinking, you know.
And Nel, for you, what was kind of the tipping point that prompted you to seek support or disclose how difficult things had become in your life?
You know, I think one of the reasons why I speak so openly about this is because I really want other physicians in this case to be aware that this is one trap that we can fall into. And I want people to know that if you're struggling or if you're suffering, that there is help and that things do get better. But at that time, I think for myself, there came a time when I just wasn't able to work anymore. I went off on a medical leave, which actually only made things worse because then I didn't have to keep myself sorted during the day. I could just do whatever I wanted. And I can't describe, because I will describe later what it feels like to be in recovery, but to be that sick and depressed and drinking heavily, and then as an Indigenous person, as a First Nations woman, I just became embedded, I think, in a web of shame and guilt and despair and hopelessness. And I wouldn't say I was suicidal, but I realized, because I have some medical knowledge, you know, that this was very harmful to me. And I thought, well, I guess this is just how it's all going to play out, right? I'm just going to drink myself and eventually I'll get some terrible complication and that'll be it. And I didn't have the cognitive ability at that time while I was sick to realize that there was a way out, right? I was just stuck in my illness and in my shame. And I think that's an important point that people don't really remember, that sort of, you know, well, why don't they go out and seek help? Well, I didn't go out and seek help because, first of all, I was too ashamed to come forward. But I literally couldn't imagine things being better. I just was living with the status quo. And because my despair was so severe, I was pretty complacent. I just thought, I'm just going to let happen to me what's going to happen. So I think that's important for people to know, or family members or friends of people who are sick and using substances, that they can't just snap out of it, because their brain, my brain literally was sick.
Well, you remind me of something that I think also applies in a more general sense anytime a physician or a healthcare worker is suffering with a significant illness. And we have this kind of feeling, right, that we know what to do, as you were saying earlier, we know how to tell a patient to manage things, but that's in the setting of our healthy brain. So that's at a moment when our brain is not bathed in, whatever inflammatory process is going on or the neurochemical alterations that are part of experiencing addiction. And I think it's one of the cognitive traps that perhaps physicians often fall into seeking help. They're not really, you think, you make the assumption, and people around you maybe make the assumption that you're making decisions with your usual brain, your day-to-day pre-illness brain. And that is really not correct at all, as you say.
I think the other thing that happens to physicians who are in difficulty with substance use is that point you made about we think that we'll be able to fix ourselves, because it's not that I didn't have medical support. I had a psychiatrist that I was seeing who was trying so hard to be helpful for me. And I really feel badly because I was not an easy patient, right? I know they say doctors make terrible patients, but I literally was not an easy patient. So I think of her with gratitude all the time. But I really thought that I could manage this all on my own, and so when you asked about, well, what brought you to the point of seeking help, I have to honestly say that it really wasn't me. Yeah. It was the people around me. It was my partner. It was some friends of mine. And I should mention actually that I had been in and out of recovery. I first started trying to go to, self-mutual aid groups back in probably around 2007. And I didn't actually go to residential treatment till 2015. So for 8 years, I was trying to seek help at different times. And I had long periods of sobriety. I had 2 years at one point, a year at another point. I probably was sober more than I was drinking in 8 years, but when I was drinking, especially toward the end, it was really bad. So it wasn't really me. It was the people around me, people from my recovery community who, we see this all the time in recovery, right? People relapse and they go in and out. And so finally, it is a little bit funny because I do have a very black sense of humor. My partner had been in contact with the Ontario Physician Health Program, and they said, sure, we can get her into residential treatment. I think it was Wednesday. We can get her in on Friday. And, he was so relieved, and he told me, he said, they're going to take you into treatment on Friday. And I'm like, I think I need until Monday. It was just like, I'm not quite there yet. I just need a few more days,
So now you talked about some of the very reality-based difficulties that physicians can experience when they are seeking support for addictions. But I want to ask you about the structural barriers that exist as well, because sometimes I think we downplay them, we glorify, seek help, call this number, etc. But we don't always talk candidly about what we need to be doing better from a structural perspective when it comes to physicians accessing those supports. And I wondered if you could talk a little bit about your experience in that realm.
So I think, to start out, I really want to raise my hands to the Ontario Physician Health Program, because I think they have one of the best programs across the country in any province or territory. They really seem to understand the situations of physicians who are, experiencing substance use challenges, but also are so incredibly supportive once you've, made that decision to be in recovery and be on that healing journey. And so that part was great. I had a lot of support. I had a clinical case coordinator who I still keep in touch with. And Dr. Joy Albuquerque was the medical director at that time. And she was, a fierce advocate of trying to, dispel the stigma around substance use and, frankly, the discriminatory treatment that people, including myself, experienced in trying to return to work. I think the one thing that employers, I get that, from a college perspective, we have to be safe and, patient safety is paramount. But when you're really doing your best and you're continuing in your recovery and you're stable, you know, being made to feel as if you're in imminent danger of creating some situation that is, you know, terrible is not the best feeling for someone whose esteem, you know, whose self-esteem is already so low. And so I think one of the things that we could do about that is just recognize that, you know, people who are in recovery and are trying to recover, you know, my intention was never to harm anybody else. I mean, I know I did, not patients, thankfully, but I hurt the people around me who love me. But we never intend to harm anybody else. You know, it's substance use is such a self-centered illness. And at any rate, so I think there were some barriers in me returning to work. I think people had some very preconceived notions, stereotypical notions of someone who used substances. You know, I think workplaces where physicians work in some ways are still pretty mired in stigma and stereotyping around people who use substances. And that includes the health professionals who work there. You know, since I've been in recovery, and I can proudly say I've been sober for over 8 years, I've been in, you know, support accountability groups with other physicians, nurses, pharmacists, for example, and, you know, people really are trying their best. And so when you return to your workplace and people are making assumptions that, you know, at any minute you could pick up a big jug of vodka and start chugging, like that was, you know, that wasn't my intention, but that's how I was made to feel. And so that was really hurtful to someone. Like I said, when you're in recovery, you start climbing back from a pretty low place, you know. When I first got to residential treatment, I remember the first few days, I was kind of wandering around with everyone else, going to the groups I was supposed to be going to, and this doctor stopped me in the hallway. He was actually, I think, the chief of staff there, and he said, you know, Nel, he said, I've seen you since you got here, the last 3 days, he said, and all you do is stare at your shoes. And he said, you know, someday you won't feel like that. And I still get a little emotional talking about that because it was like he had that faith in me that I didn't have yet. And so that's the kind of treatment I think that people deserve. You know, they deserve to be treated with dignity and with respect, and a hopefulness. Like, instead of, you know, you're a misbehaving physician, you're a disruptive physician, instead of that approach being, you know, we're here walking alongside you. And I think that would go a long way toward having physicians feel comfortable coming forward to seek help. If they didn't feel as if, you know, I think physicians, a lot of us build our whole lives around, to a certain extent, not completely, but on what we do and who we are. It's a big part of how we see ourselves. So when that all comes crashing down, there's not a lot left in some ways. And of course, then there's that extra layer of, you know, have I ruined my career? Am I ever going to be able to get back? Am I ever going to feel good about myself again? You know, and I'm here to, one of the reasons I'm agreeing to do this interview is because I'm here to tell those physicians that all of that is possible. And all you have to do is really take life, you know, a day at a time, and you'll amaze yourself by how much better things get. You know, I'm at a point in my life where I don't think I've ever been happier. I've never functioned more fully and better in my entire life. And a kind of a great point to make with a bit of humor is, you know, sober colleagues are the best colleagues because we work hard. We can always be on call. We're never hungover. You know, like, we're always there. We become very dependable, reliable colleagues. And I think that's a completely different way of looking at physicians in recovery.
That story that you just told about your colleague gave me a chill. And it makes me think of, this paradox about us that we can be so compassionate towards our patients. And again, as we've talked about, we're not always compassionate towards ourselves. But there is sometimes this phenomenon where we can just be absolutely horrible to each other, particularly horrible to other physicians who are experiencing illness and manifesting, some form of what we perceive or would superficially call weakness. And I wonder, as a psychiatrist, what do you make of that? What do you think is behind that?
So I think what it really comes down to when physicians are unkind to other physicians who are in difficulty, I think really what it comes down to is there probably is something in that physician who's having trouble that triggers something within that person, right? Because the reality is, and I've become so comfortable speaking about being in recovery now, and recovery kind of makes me be, scrupulously honest about things, is that we all struggle, right? We all, all the way back to the beginning when I started this interview, I said, life happened to me. And life continues to happen. Things get turned upside down, and there have been other losses since then and other challenges. But I think it makes some physicians feel afraid that the same thing might happen to them. And that might be a very unconscious thought, right? Or just that the whole culture of medicine is that we must be strong, we must be seen to be perfect, we must be competent. And seeing the humanity actually in another person, or even frailty for a moment, is unacceptable, right? So we all have this persona that we have to maintain, that, I know exactly what's going on with that patient. I have the perfect treatment plan. I'm always competent. I'm never make mistakes. That's the culture that we created. And so when someone is struggling, I think that disrupts that balance, and it can be distressing, I think, for people.
Now, the last thing I want to ask you has to do with vulnerability. And you talked a little bit about putting an authentic story out there, the power of that, how that works in service for our colleagues to help us make changes to our culture. But I want to ask you, as a clinical tool, as something that is of service to patients, because so often we have these high boundaries where people don't know anything about us, and learners and early career folks think they can never divulge that humanity, the fact that we struggle to. And I just want to end by talking to you about what it's been like to have patients and people in your professional community who you may have clinical relationships with know what you've been through. How does that become something that you are using for the greater good?
I'm not sure I would say, I'm so glad that I went through all that. But it definitely has made a difference for me in the work that I do, both when I was working as a clinician and now as a physician working in public health. I have yet to encounter a negative experience with a patient if I have even divulged in information that I'm in recovery. I know I did it a couple of times when I worked in the emergency department. And again, I have to say, as a First Nations woman, I don't see divulging some things about ourselves as a lapse in boundaries, right? If it's going to serve the patient and make it a safer experience for them. And I'm so fortunate now in my role at First Nations Health Authority, where I get to be open and honest and be my authentic self. I do a lot of public health messaging. I do a lot of public speaking across BC with our different regions and our chiefs and our health leaders. I almost always mention that I'm in recovery, because I think what it shows people is that it's just a way to destigmatize, right? And to have people say, well, this is no different than someone who experiences a different kind of chronic illness. Yeah. And I get to, we do a lot of public health campaigns where I work, and We have the Sober for October campaign, where we ask people to either think about, reduce, or limit their drinking of alcohol during the month of October. And, you know, it's the only challenge I ace, you know,
Yeah.
and I get to do a lot of messaging that month and make it seem to people that actually being in recovery is a good thing. You know, and with the recent release of the Canadian Safe Drinking Guidelines, like I think anybody can do a rethink of where they're at in terms of their alcohol use, and do some reevaluating and just try to be as, you know, safe as possible. And honestly, I can't describe to you how good it feels to be who I am now. Not just, you know, I don't define myself by my alcoholism. It's a part of who I am. It's not the whole part. But you know, the best thing is every single morning I wake up and I feel clear and I feel able to take on the day, and I have the tools that I need to take on both, you know, the work, my demanding job, and the demands of my life. And I would wish that for everybody, and for physicians especially who might have the chance of seeing this. If you're in any doubt at all, if you're struggling, I would really encourage you to seek help with the physician health program in your province or territory, and start that journey. And whether it stops and starts like I did for 8 years, whether it continues solidly like I have for the last 8 years, it's not going to be something that you'll regret.
Well, Nel, it is just a privilege to have this conversation with you this morning. I feel both in awe of the work that you're doing, but also just so grateful for it, and so proud to be a fellow McMaster graduate with you as well.
Thank you. It was a pleasure to be here.
Thank you.